Hello, hello. Thank you for joining us this morning. This is going to be such an interesting conversation. And so, as everyone is entering, because we see folks entering in and we also see folks in the waiting room, we're going to take a few seconds to woosah so that everyone is ready and open to the material. And we're going to start our introduction shortly so you know who the heck we are, because you have all taken a significant portion of your day from 9 to 11, which is like, for some places, the witching hour, right? Where everyone's coming in, everyone wants services, everyone wants something. So from 9 to 11, you have decided to be here with us. And so we very, very much appreciate that. Okay? So, Carrie, whenever you're ready, please take it away.
Okay. Good morning, everybody. I'm Carrie Dunn Herrera. I'm the Assistant Director of Health Promotion at Healthy Capital District. We are incredibly grateful to be bringing this professional development series in partnership with SAMHSA and the Opioid Response Network, and also incredibly grateful and absolutely thrilled to have Dr. Blackwell sharing her expertise, leading the conversation, and helping us all address challenges that we face in our different work areas or personal areas and beyond, and the things that are facing our community. I've included an introduction in the chat and hope you all will introduce yourselves. Please feel free to leave your website, contact information, the role that you play at the agency. The chat box can be a great place to find that warm handoff you've been looking for, that resource you've been looking for, and to make connections. Also, you'll see at the very top of the chat, I listed our website with our webpage that's dedicated solely to the community health professional. There you'll find resources to support people that you're working with, but you'll also find training and professional development opportunities, including our Certified Recovery Peer Advocate professional support program. So please, visit the site, and also please feel free to leave us any feedback. Lastly, at the end of this presentation, there will be a QR code, and please take your time to fill out. It's a very brief 2-minute survey, but it's what allows us to have these events for free. It allows us to continue the funding, but also it allows you the space to give feedback and help us direct for and give us ideas for additional events. So without further ado, I'm going to pass it over to Katie, and I look forward to the event today. Welcome, everyone.
Thanks, Carrie. Good morning, everyone. My name is Katie Cunningham, and I am a technology transfer specialist with the Opioid Response Network, or the ORN. The ORN is a SAMHSA-funded organization that provides free training and technical assistance to communities and organizations related to opioid and stimulant drug use. And we focus our efforts in the areas of prevention, treatment, and recovery. And so what we mean by technical assistance is that we offer educational resources, training, guidance on implementation of evidence-based practices, whatever our requesters really need, all free of charge, with the goal of strengthening local organizations and community responses to the overdose epidemic. And we accept requests from organizations of various sizes and backgrounds, from hospitals to local nonprofit organizations, from providers to peer advocates. So I am part of the team that handles technical assistance requests specifically in New York State, but the ORN has a network of subject matter experts available across all 50 states and US territories who can provide training and technical assistance that's catered to the specific community that they reside within. So if you are interested in learning more or submitting your own request to the ORN, you can go to our website, which is opioidresponsenetwork.org. I'll also put it in the chat. And submitting a request is a really simple process. You just click the large submit button in the upper right-hand corner of our website, and then you can submit your request in 5 to 10 minutes. It's a very short form, and you don't need to know all the specifics of what you're looking for. You can reach out to us and we can discuss that, because within 1 business day, you'll hear back from the ORN TTS from your region to learn more about your request and the goals you hope to achieve, and ultimately to connect you with the consultant or resources that will meet your needs. And again, all training and technical assistance provided through the ORN is free of charge, covered through SAMHSA. So if you'd like more information or have questions or anything regarding the ORN or a request you're interested in submitting, I'll put my contact information in the chat and you can reach out directly, or you can head to our website. And also everyone will receive an email in the coming days with instructions with the slides and for instructions for accessing any CE credits. And at the end of the training, I'll also put the link to our feedback survey that Carrie mentioned. And I think that's all the housekeeping I need to share. So without further ado, I will pass it off to Dr. Blackwell, and I hope you all enjoy the training.
So thank you, Katie. Thank you, Carrie, for that introduction to, the space and what we hope to accomplish in the space in regards to this virtual learning space. And the thing is that our presentation, or the presentation today, is called The Caring Connection, and it's really making the connection between trauma-informed care and recovery planning. And again, my name is Dr. Dolores Blackwell. I'm a licensed clinical social worker in the state of New York, but in a few other places. And I am really, really excited to present this information because when we talk about trauma-informed care, many of us have different levels of understanding of what trauma-informed care is, how do we engage in trauma-informed care, etc. We know in a variety of different places and spaces that trauma-informed care is something that we are quote unquote doing, or we should be doing, etc. We hear the term, we may understand it, but are we actually participating in trauma-informed care? When we talk about trauma-informed care individually, we have control over that, but we also need to begin to lean into at some point, are the spaces that we are seeing clients actually trauma-informed? Okay, because it's more than just the individual contact that we have with folks. It's about the organization itself. And we're going to lean a little bit into that conversation today. Now, we're going to be together until approximately 11 a.m., and there is no way in heck that we could cover all of this information in 2 hours. Why? Because when we talk about trauma-informed care, we talk about recovery planning, we talk about connecting those two moving pieces, it is an ongoing process. So part of that process is really beginning to lean into, okay, what's the key information that I need to begin to process this, begin to look at it to see if I, as an individual provider, are participating or is participating in trauma-informed care, utilizing with our clients, creating an environment that is trauma-informed, and thinking about recovery planning, but also is the organization, is the space that I find myself actually operating within that trauma-informed prism, okay? So I'd always like to say that. The other thing is that throughout this presentation, I get very excited about information, and this is with no coffee. So this is just who I am as an individual, okay? So you may see me moving my hands, etc. And I always like to say that's because I'm invested in this topic, okay? We have a lot of folks here, and different folks have different levels of understanding of trauma-informed care, recovery planning. And so hopefully my excitement kind of spreads to folks out there in the learning community, but also some of this may serve as a reminder for folks, and some of it may be brand new information, but the presentation is set so that anyone, whether you have this information from prior spaces or prior trainings, and or if this is new information, you will have an opportunity to participate. There are also opportunities for you to participate built into this training, okay? So there is no kind of like everyone kind of sits in the ether. The ether is coming in. So there's going to be questions, there's going to be opportunities to interact. And so I hope that folks feel comfortable to interact, ask questions, etc., because this is something that helps to liven the presentation, but also you don't have to sit back kind of casually or sit back and just kind of, I'm going to lecture to you. That is not the way that I train, okay? That's not even the way I share information. It's a back and forth, okay? So our technical term is the caring connection, trauma-informed care and recovery planning. And as Carrie and as Catherine have talked about, this is sponsored through the Healthy Capital District and also through the Opioid Response Network, okay? And hopefully I'll be seeing some of you in other trainings, because I think we have a whole training series. So this will be virtually. I think I have a couple of in-person trainings. So if you don't get an opportunity to see who I am, this particular, because you see this box, right? You will actually get an opportunity to see me at a later date in person, okay? And you'll get to see me without the glasses, because the glasses can be a lot, okay? So let's go into our learning objectives for today, okay? We're gonna lean into this material. So what we're hoping to do is to learn or review the core components of trauma-informed care and lean into recovery planning a bit. We'll also kind of get into that conversation, assessing your own, you beginning to assess your own preparedness to provide trauma-informed care during your individual contacts with clients, okay? And also learn some strategies to initiate trauma-informed conversation before and during and in conjunction with recovery planning, okay? A lot of when we talk about trauma-informed care is about creating a safe space. Okay, it's about creating a safe space. Now, the one thing we want to lean into is when we talk about the concept of safety, right? We have kind of a lot of different ways that we connect meaning to safety. For some folks, it's physical safety. For some folks, it's emotional safety. There are all different ways that we lean into safe. And we need to understand when we're working with clients, when we're working with folks, what is their definition of safety? Because it is one of the core components of trauma-informed care, creating a safe environment where folks feel like they can come, seek out services, receive assistance, etc. And they feel like when they come into the space that they have a sense of they can take a breath. They can take a breath. Because for many of the folks who you may be coming in contact with or are coming in contact with, we don't know what they experience prior to even coming to your space, okay? We have folks who are coming from environments where they may feel unsafe, coming through environments where they feel unsafe. There are multiple social determinants of health that are impacting folks, impact their substance use, that we need to take into consideration when we're leaning into trauma-informed care and recovery planning. So when we think of it from that perspective, when that person got up that morning, did they feel safe in what safety meant for them? What did they need to do to come to the program, to access services, whether through telehealth or coming to the program physically? And where does that leave them in regards to their emotional safety, where they feel, how they feel when they get to you, when they talk to you, etc. That's the key kind of concept to remember. It's about a safe environment, but also taking into consideration the things that may be happening for folks prior to them even seeing you the very first time, or seeing you in the waiting room, etc. And that's something that we need to remember when we talk about trauma-informed care. It doesn't just start with when I go out to meet the person or bring them into my office. There is so much that can happen prior to that we need to take into consideration. That we need to sometimes, when I've worked with clients, I will literally say, you know what? Let's take a couple of minutes and let's take a woo-saw moment and just breathe. Because this is a safe place where you can breathe. Okay? Safe place where you can breathe. And so when you start from that perspective, you're starting immediately. Breathe. Okay? Because when we talk about trauma, when we talk about the things that folks have to survive, go through to get to where you are, they may not have taken a breath. And so taking that few seconds, breathe, and then we can get started, okay, is one of a great strategy that you can utilize, okay? So the other thing I want to mention is that even though I am using my slide deck, you will hear me say a lot of things that are not on the slide deck. So you will, of course, receive a copy of the slide deck, but I ask that you kind of stay plugged in to the material, plugged into the conversation, because I may have a slide up and I may be talking about 10 other things that are not on the slide. Okay, so just kind of, I'm going to ask for everybody to take a moment and take a breath now. Just take a deep breath and just be present. I see people like, what? Yes, just breathe. Okay, just breathe. Okay. If someone, as we are going through the material today, has what I'd like to call an ouch moment, where they may be activated by something that we are talking about today, please feel comfortable. Please feel okay to take a moment to step away. To either, you can turn off your camera, you can take a moment to breathe, etc. Because when we talk about the concept of trauma, right? Trauma is not just experienced by the folks that we work with. Trauma can be experienced by anyone who is in this virtual space. And so we want to respect that some of this information may activate things for folk. And so I wanted to invite you that if you feel activated in any way, that you can take a moment and breathe. Okay. Now, one of the things I want to remind folks is that you're hearing me use the word activate, right? And so one of the key components when we're talking about trauma-informed care and trauma is to begin to realign our use of language, right? Realign our use of language. We've all heard the word triggered or re-traumatized, or we're triggering folks, or what are your triggers, right? In the trauma space, we are moving away from using that word trigger, okay? And we're realigning the language to use activated, right? Why are we using the word activated? Because the very word trigger can trigger folk, okay? Can reactivate folk. And it has less of a violent, confrontational connotation to it when we say activate. Right? So part of when we're talking to folks about trauma and we're leaning into what this looks like for them, how they're experiencing it, is we're beginning to do some psychoeducation, okay, around the language. And so talking about activation versus triggering, okay, is an important part of that. I see some people smiling. I hope they're smiling at me, that they're smiling at the information. I won't say who those people are who I see smiling, but definitely it's always good to see that. So in this presentation, and as you continue to think about this, think about how you're realigning the language from trigger to activation, okay, to activation. So when we're talking about trauma, let's talk about some key thoughts to consider, okay? So when we think about trauma-informed care, we want to imagine a place where folks are asking, what happened to you instead of what's wrong with you, okay? When we think about the concept of trauma, in many ways, it's what's wrong with you? What the heck happened to you? Why is this happening to you? We want to realign that and think about what happened for you. How did that impact you? What are your thoughts around it, etc. So we really want to think about our language. When we talk about trauma-informed care, we want to create a space that understands that past trauma can be triggered/activated by experiences in the past. Now, remember, I'm including both of that language because that is familiar to folks, but I'm asking you to begin to move to shift it, okay? So this is the thought process that anyone can be activated by something that is happening in the present. When we talk about trauma, it can be a smell, it can be a place, it can be a phrase. We can hear of folks who are reactivated by a television show. Any of these things is a possibility, okay? So we're kind of committing ourselves that past trauma can potentially be activated by an experience in the present. We also want to imagine a place and create a space where we are committed to supporting people as they heal, okay? As they heal. We're hoping that folks are in a space where they want to begin the healing journey, but we also need to recognize that when someone comes in to work with us in the variety of different places and spaces that we work with folks, whether we're going to their home, whether we're in the hospital, whether we're in a treatment facility, etc., that folks are in different places along their healing journey. Some folks may not have acknowledged the trauma that has happened for them or the impact of the trauma. Some folks, as you talk about the different levels and different things that have happened to them, may be able to focus on one aspect, but not focus on the other aspects and the other consequences or the other connective tissue to what happens on the day-to-day life. We know that some folks that we see are survivors, right? We use the terminology survivors. Now, when I talk about survivors, I want to talk about expanding that conversation, expanding that word, right? Because if someone comes to see you and they're able to talk about, let's say, for example, I was hurt by someone I trusted, right? That is what they can focus on at that particular time. However, when you hear and you're assessing, you're hearing so many other things that are happening. It could be potentially poverty. It could be homelessness. It can be discrimination. It could be so many other things that folks are navigating, but it has unfortunately become a normal experience for them. Okay, and so we need to acknowledge all of that in this conversation and as we move forward. That trauma is not just particularly focused on a single event or the thing that folks are, that's what I can identify as trauma. The day-to-day functioning of living in poverty, the day-to-day functioning of food insecurity, etc., all has a role to play. Okay, so just kind of leaving folks with that. And so when we recognize trauma, it can be a single event. And many times when folks do begin to unpack trauma, they go with a single event. But more often than not, it's multiple events that occur over time. So it can be complex, it can be prolonged trauma, it can be things that are happening just before they came in, okay? We've worked with folks, or you can work with folks who they wake up and they wake up in an unsafe place, trying to get out of the door to come and see you. So that in itself can also be very traumatic in how they survive that situation. So more often than not, it can be multiple events that occur over time that may be occurring as they are working with you. So it can also be interpersonal violence or violation, and especially at the hands of an authority or trusted figure is especially damaging. Okay, so we're talking about young folk. We're talking about folks who teachers. We're talking about parents, etc. Okay, can be particularly damaging, and this is connected to the ACEs study, right? The adverse childhood experiences. And we're going to talk a tiny bit about that today. Okay. Now, this is not a all-inclusive definition of trauma because we do understand that there are clear diagnostic criteria in regards to what meets the criteria for PTSD, acute stress disorder, etc. But this is just some moving pieces of that. So let's go back to our social determinants of health, which I began to lean into. So conditions in the environment in which people are born, live, work, etc., can affect a wide range of health and functioning and quality of life, outcomes and risks. And so we need to consider the social determinants of health that people are experiencing, connected to their trauma, connected to their substance use, okay? When we talk about the person as a whole, when we talk about leaning into person-centered care, whole person, etc., when someone comes in, they come in with a presenting challenge, right? A presenting challenge. For some folks, that is substance use. For some folks, that is mental health. For some folks, it's a combination. It's comorbid. It might be medical concerns, etc. When we lean into the premise of whole person care, we are taking into consideration all of who that person is and all of the experiences that they are either having currently or have had in the past, and how it impacts their quality of life. Okay? When we lean into the premise of recovery planning, if we don't take into consideration the whole person and all of who they are, we may be missing key factors that impact the recovery process. Okay? We can all kind of connect to someone who we have attempted to do some work around recovery planning and decreasing substance use, et cetera, because we're also talking about harm reduction. But someone says, you know what? The only way I can deal, the only way I can wake up in the morning, the only way I can function throughout the day is if I use a particular substance. That's the way that I keep the flashbacks at bay. That's the way that I can take a break from the pain. Okay? And so when we're assessing and we're talking about the whole person, we need to lean into the social determinants of health. Okay? That assessment, all that information we pull together when we're talking about recovery planning, while as we're going through the process and the client may prioritize other things, we need to keep those things in the back of our mind. How does this impact their recovery? Okay, so some of the things that we want to look at that enhances quality of life and has a significant influence on health outcomes can include safe and affordable housing, access to quality education, public safety, availability of healthy foods, emergency and health services, and environments that are free from life-threatening toxins, okay? So let's even expand this a little further when we're talking about the social determinants. So some of the key areas that we can look at is economic stability, neighborhood and physical environment, education, food, community and social context, healthcare systems. So we can talk about access to care. We can talk about social supports that folks have in the community, hunger, okay, access to healthy options, education, physical safety. In rural communities, we talk a lot about transportation. I had a presentation yesterday where we leaned into the whole premise of transportation and the stressors that that can bring, okay, before someone even gets to the program, okay? Safety, again, leaning into that concept of what is that particular person's concept of safety, not relying on our thoughts around safety. Employment, income, debts, medical bills, support, okay? It is one of the significant stressors that many of our folks are dealing with, economic instability, okay? And how does that impact their ability to navigate the challenges that they're facing, okay? For many of our folks, some of the ways that substances are utilized as an escape, a break, okay? A break from life, a break from hurting, a break from pain. And as human beings, we do amazing things to avoid being uncomfortable and being in pain. We just want it to stop. And so when we talk about trauma-informed care, it is with the thought process that everyone is dealing with some sort of challenge that could impact their recovery, their health, their mental health, etc. And so I set the stage for that because we can talk about the moving pieces of trauma-informed care, but it's about the awareness that anyone and everyone, including ourselves, have had experiences or currently may be having experiences that activate thoughts, beliefs, ideas, activate particular behaviors, etc., in order to deal with, and we can fill in the blanks, okay? So again, you'll have access to the slide deck, so you will have an opportunity to take a look at all of this, okay? And as I told you, I'm going to say a lot of stuff that is not on the slides. So I hope that folks are kind of connecting to this. Before I move forward, what are folks' thoughts about the social determinants of health, about trauma, and about connecting those two moving pieces? Does anyone have any thoughts or any feedback on that? And please feel free to unmute yourself. I see one person has their hand raised, and Dominique, please feel free. Please share. Okay. Dominique, if you're having, are you putting something in the chat, or if you, oh, okay. You can put something in the chat. Can we check the chat to see what Dominique is saying? Because some folks may not have access to audio. But I'm going to move to Armando while we figure out what's happening for Dominique. Armando, please.
It's very reminiscent of Maslow's theory of hierarchy of needs.
Mm-hmm. Absolutely, absolutely. And I am a firm believer of the hierarchy of needs, because if we don't deal with food, clothing, housing, etc., folks do not feel like they're ready to deal with the higher level of needs. Because if I am hungry, if I can't figure out where I'm going to lay my head down tonight, okay, I'll come to the program, but I am so not ready to talk about my feelings. I just need to figure out where I'm going to lay my head down tonight. Okay. Thank you for that, Armando.
You're
Dominique.
welcome.
Dominique?
Having trouble unmuting, but
Okay.
everyone should be able to
Okay.
unmute themselves.
Oh, there we go. We have someone else, Akil. Hi.
Hey, hi. I was looking at this, and we look at these social determinants of health quite a bit in our in our role with working with the criminal justice population. But one of the things that stands out is that, for a lot of folks who are currently incarcerated, um, it's very helpful to be trauma informed, but it's also very difficult for a lot of individuals to be really present and be able to react on the things that they need to approach and deal with the trauma that's brought them there and the trauma that they're experiencing on a regular basis in the prisons. And I'm not just talking about just men. I mean, it's men and women. But a lot of times for men, it's even more difficult because a lot of times they're not really taught. It's not really enforced in their lifetime to be able to be present and open and in touch with certain emotions, especially when you're in that type of environment. So a lot of times we're unable to really make any real breakthroughs until after they've come home to the community.
Mm-hmm, mm-hmm. And so this is great that you mentioned that, Akil, because we're going to be doing a presentation, I think, in a couple of weeks around working with folks with current and past criminal justice or justice involvement. And so we're going to lean into some of the strategies around that. And I will give you a heads up that our kind of interactive exercise is focused on someone who was incarcerated for 20 years. Okay, and so thinking about that, and thank you for bringing that up, because when someone is in the midst of experiencing these things, it is so much more difficult to see their way past it for some folk, right? And incarceration is one of them. Before I move forward, I want to make sure I didn't miss anyone. And I keep saying Dominique because I want to make sure she was the first one, or they were the first one who raised their hand. I want to make sure that they have space. So we'll definitely try to figure out what that looks like for Dominique. So definitely later on, you will have an opportunity to, of course, provide feedback. So thank you for that. In regards to working with folks who have justice involvement, what does this look like? Folks who are thinking about their basic needs, and we're talking about treatment, or we're talking about engaging them in treatment. What is the impact of that? That is all a part of this conversation. okay? So the infamous ACEs study, right? Folks have heard about the infamous ACEs study, and it's infamous in a good way because it is one of the watershed moments that talked about the impact of trauma. The ACEs study, which is the Adverse Childhood Experience Study, really leans into adverse childhood experiences and the impact that they have not only on young people at that current time, but future challenges that they may experience or manifest in their development, okay? So ACEs was a longitudinal study, which we continue to use it, right? But I think that we also need to lean into additional work that is being done with particular populations around ACEs, okay? So for example, there are a number of studies out there that are focusing on urban communities and ACEs. There is a study, I think, out in New Jersey that is looking at folks who are, I think it's in Newark that they're doing that work around gathering information around adverse childhood experiences from adults and the sense of what that looks like for them, okay? So if you've not had an opportunity to look at or check out the ACEs study, please do so because it provides you some additional context in regards to really leaning into trauma. So we're talking about social determinants of health, we're talking about adverse childhood experiences, and these are things that we need to consider when we're working with folks we come in contact with, okay? So let's talk about trauma-informed care, because now we've been kind of like buzzing around it. So let's lean into some of the concepts around it, okay? So we're going to talk about this just very kind of broad stroke, okay? So when we're taking a trauma-informed perspective, it allows participants to feel safe, okay? And remember, we're leaning into what safety feels for folks. And we should absolutely ask folks, you know, what does safety mean to you? Okay, because generally no two people have the same exact definition of what safety means to them. So if we're talking about creating a safe environment for the folks that we're working with, inevitably at the beginning of that process, as we're building a therapeutic relationship or rapport, we're going to ask, what does safety mean to you? How can you feel safe? Or what can I do to create a safe space for when you come to the program? And that you feel comfortable in talking, that you can breathe, etc. You can use any number of questions or organic ways to really lean into this information. But we do need to ask folks what that means for them. We also want to lean into not reactivating folks, reactivating their traumatic experiences by giving them agency and voice within the treatment process. Now, this goes back to something that Akil mentioned when we're talking about folks who are in the justice system, such as in jails and in prisons. And remember, there's a difference between the two. There's a difference between jails and a difference between prisons, right? How do we give folks a sense of agency in spaces where agency is not something that is cultivated? Okay, so we need to lean into that. We also want to lean into the premise of when we have folks who come to us who have potentially been challenged or overcome or survived intimate partner violence, who have survived incarceration, who are in daily mode or daily survival mode. How do we give them agency when in many ways a variety of different systems, places, and spaces aim to remove their agency, remove their voice? Okay, so this is an ongoing thing that we need to lean into. So this is why this is not something that you just do a one-off. This is consistent work, consistent process that you need to lean into, particularly in the treatment process. So when we're talking about recovery planning, when we're talking about service planning, etc., how do you give folks their voice? Okay, and take the time to do that. Okay, so I'm going to give you a quick story of how this could potentially impact. I worked with a client some time ago who left a intimate partner violence situation that was about 10 to 20 years that this person was involved in that particular relationship. They had extricated themselves from the relationship and were seeking treatment. Now, during that process, we're doing the assessment, we're working together through the assessment, etc. And we are putting together a service plan or a treatment plan. One of the things that became really apparent is that this person struggled to use their voice to identify the priorities for them of what they wanted to talk about or what they wanted to deal with in treatment. Now, we all know that based upon time constraints that sometimes we absolutely have to get that treatment plan or that service plan in place. But was it more important for me to have this treatment plan or service plan in place, or to allow her to find her voice, to help her feel like it was a safe place to use her voice and talk about the priorities for her? And that took some time. And I have to say there was a lot of wrangling sometimes, because it almost felt like it was almost the reenactment of, you tell me what to do, because that is what the perpetrator had done, told her what to do. Okay, so I would have been reactivating or reenacting that relationship if I had pushed the development of that treatment plan. Now, in full transparency, of course, I had to document why it was taking me so long to do that treatment plan, right? Because we do have to do that. But it was so important to allow that process for her. Subsequently, once she did it, it opened up the work wide open, okay? And she felt safe, okay, to do so. So this is something that we need to consistently pay attention to. So we know that trauma-informed care is a strength-based framework that is grounded in understanding of and responsiveness to the impact of trauma. And this emphasizes that physical, psychological, and emotional safety for both providers and survivors to rebuild a sense of control and empowerment, okay? We know that when we're working with folks, we can be activated as well. And so how do we have a safe space for us to have a collaborative relationship is also important as well. So we also want to lean into the concept of trauma-informed organizations and programs are based on the understanding or understanding of vulnerabilities and triggers of trauma survivors that traditional service delivery and approaches may exacerbate, right? So when we're talking about the agency, when we're talking about the organization, while you have a sense of control over what is happening in your individual contacts with a client, it is also about the organization and the supports that are in place to provide trauma-informed care. Okay, because remember, your contact with the client starts from when you step outside into the waiting area and you may see the person, right? But there's so much that happens when the time someone walks in the door and who they come in contact with. So trauma-informed care is everyone's responsibility. Okay, everyone's responsibility. Okay, so what does trauma-informed care offer? It improves our desired outcomes. It supports trauma recovery by reducing re-traumatization and can potentially provide a corrective emotional experience, such as the case that I talked about a few minutes ago, and decreases our own vicarious trauma and compassion fatigue. Because when we're working with folk, we are impacted by everyone that we see. Okay, when we're talking about that collaboration, when we're talking about the relationship that we're building with folk, right? It is not just the participant, not just the client. We are a part of that dynamic. So we also need to be mindful and take care of ourselves as well. And one of the ways that we do that, decreasing our own vicarious trauma and compassion fatigue, is a use of supervision, and peer contact and talking things through, MDTs, a variety of different spaces to really process what's happening. So, what are the core principles of trauma-informed care? And for some folks, this may seem super, super familiar. And for some folks, this may be brand new information. And so what we're leaning into is the awareness that everyone knows the role of trauma. Okay, everyone knows the role of trauma. So that includes not just you as potentially the practitioner. It can include the front desk staff. It can include the maintenance folk. It can include the doctor, the nurse. Everyone has an awareness and knows the role of trauma. Okay, it is the assumption that everyone who comes into a space or a place may have had some sort of traumatic event or experience that can potentially be activated while in the space. It's also safety, ensuring the physical and emotional safety of folks. And this looks different for different folks. That's why it's important for you to lean in and to ask folk, how do you feel safe? What makes you feel safe? What makes you feel unsafe? Are you safe? Okay, are you unsafe? Okay, and really sitting back and being present to hear the full complement of those responses. Also, it's leaning into the trustworthiness. Can folks, when they come to meet with you, when they come into the program, etc., are the tasks clear? Are there appropriate boundaries, etc., in place? Okay, trustworthiness. Are you who you say you are? Does the organization do what it says it's going to do, etc.? That all kind of lends itself to trustworthiness. Also, choice is respecting and prioritizing the individual's choices and control. And I like to equate this, and when I do this in person, I lean into the concept. I'd like to do this exercise where there's a wall, right? And we see people moving towards that wall, okay? And that wall hurts like heck, right? And our kind of key responsibility, our first thought is, if I see somebody run into a wall, I'm like, hey, stop. I may even jump in the way of them hitting that wall because it's going to hurt like the devil, right? But our responsibility is, if we're seeing folk making choices, right? Those are their choices. That is them exercising their sense of agency. And we are walking along with folks in this journey. We are not playing, we're not jumping in front of folks, trying to reroute their choices. And this can be hard. It's very easy when we see folks making choices that are positive and helpful and all of that. It's incredibly difficult when we see folks continuing or engaging in choices that are harmful and not helpful. When we see someone who may have just received a diagnosis of heart disease or hypertension, etc., and their substance use is directly impacting their health, but yet they are not in a space to decrease or stop. How do we provide support, okay, of those choices? It's that doggone concept of self-determination. It's hard, okay? That collaboration. We're sharing power with folk, okay? We're sharing power. Remember that relationship? It's a dance. It's side by side, okay? And when we think about a dance or we think about a side by side, there's no leader. It's like we're moving together. We're moving together. And when we think about all of this in that concept of collaboration versus me being the expert, me telling folk what they should or should not be doing, either through conscious language, discussion, etc., or unconsciously responding to our own stigma, implicit bias, etc., then that is not trauma-informed. Okay, we need to be very, very thoughtful around that. And it's a consistent empowerment, okay, empowerment. And some of this intersects, right? Some of this kind of connects to each other. So we're talking about choices, we're talking about empowerment, we're talking about prioritizing client empowerment and skill building, because we know that clients are the best expert on their lives, okay? And so these are the core principles of trauma-informed care that you want to lean into, okay? Second, okay. So I want to lean a little bit, just a smattering on the organizational components of this, right? Because we need to think about, from an organizational level, you know what, let me be transparent. Trauma-informed care is not just a catchphrase. It's not something that we say that we're doing. Okay, it's something that we are actively engaging in on an ongoing process. It's not a one-off. It's about leading and communicating the transformation process, as TIC implementation is an ongoing process. It's not just about looking at one set of policies, okay, we're done. It's about looking at the ongoing process of continuing to look at those processes, continuing to look at changes, and engaging in all of that as it occurs. It's not a one-time thing, okay? And so during that process of leaning into, are we continuing to be a trauma-informed space? We also want to engage clients because they experience this in the planning and changes as they occur. We also want to lean into the premise of training clinical and non-clinical staff members, okay, from an organizational level. Because as I lean into some information in a bit, trauma-informed care does not start just when the client comes in to see you or when you engage the patient, etc. It's from the time they walk in the door. Okay, because that's what we can do. That's what we can contend with the time they walk in the door. We can be aware of the other challenges that they may face coming to the program, coming to the hospital, coming to the space. But the things that we can control are when they come to the space. Okay, and that includes interaction with the front desk staff. That includes interactions with folks who they may come in contact with in the waiting area. That includes interactions with the maintenance folks. It includes interactions across the board. And so when we talk about trauma-informed care on an organizational level, is everyone familiar with what trauma-informed care is? And are we all operating on that? Okay. Creating a safe environment, which I've leaned into, and preventing secondary traumatic stress in staff are organizational level considerations that we need to lean into when we talk about trauma-informed care. So creating this safe environment, okay, which is what we're going to lean into now. Okay, give me 1 second. So what does that mean, create a safe environment? Okay, so we definitely need to lean into the physical environment, right? So we're talking about waiting rooms. Does the waiting room create a safe space? There are opportunities, there are times where there are things happening in the waiting room that can activate folks or reactivate folks, okay? The way that challenges are dealt with in the waiting space can activate folks, okay? Paint color. All of these different things can be a part of this concept. Parking lots, if you're in a space where there is parking or parking lots, right? What does your parking lot look like? Right? The lighting, all of that is a part of the physical environment. Your office, your cubicle, all of that is a part of the physical environment and is a part of creating safe environment. Because imagine you're saying to someone, you can feel safe here, but yet they look around and it feels anything but. Okay. Welcoming clients to ensure that they are respected and supported. And that goes back to your front desk. How are folks greeted when they come into the program? Okay. If there is a wait time, let's say, for example, are folks included in that process? I'm sorry, you know, the provider is a little bit behind. I'm sorry about that. That's respecting their time. Okay, just things like that. Again, the creation of safe environment and things that we sometimes forget are a part of this trauma-informed care component. We also want to ensure that staff that have contact with clients maintain healthy interpersonal boundaries and can manage conflict appropriately, because sometimes there's things that happen that folks are witness to that can activate folk. Okay, so we want to be thoughtful about that. We want to have maintenance of consistency of schedules and procedures and transparency around communication that is consistent, open, receptive, and compassionate. Okay, again, we go back to the tone, the language, how we communicate with folks, and also being aware of how an individual's culture can impact how they perceive trauma, safety, and privacy is a big one, right? It's a big one. Because what we might see as being traumatic, right? Another person might see as survival. So we're leaning into that, okay? Okay, so of course, I'm now going to open it up to folk to ask 2 questions, and you can answer if you feel comfortable or not. What is your role in creating a safe environment for the clients you come in contact with? And is trauma-informed care embraced by the spaces you work with clients? Would anyone like to open that up? Dennis, I see you have your hand raised, please.
Yes, I work for an organization in upstate New York called St. Joseph Addiction Treatment and Recovery Centers, dealing with clients that suffer from substance abuse disorders. We have an inpatient program, outpatient, sober living environments, and we're in 2 different jails up here, and I work at the Essex County Jail. Now, we've adopted as an organization the sanctuary model. And if I can read some bullets of what it is, it's an organizational and treatment intervention based on the tenets of trauma theory and an understanding of systems theory. Sanctuary addresses the way in which trauma, adversity, and chronic stress influence individual behavior, as well as recognizes the way in which whole organizations can be influenced by these factors. Sanctuary is based on a set of guiding principles, as well as some specific tools that reinforce the philosophy when practiced by staff and clients on a daily basis. And creating sanctuary is a deeply rooted change initiative that requires sustained commitment and work over the course of years. There are 7 commitments that are created within sanctuary. These pies slices are growth and change, nonviolence, emotional intelligence, social learning, open communication, social responsibility, and democracy. So when we adopted the sanctuary model, all staff within our organization, which is over 100 employees, were fully trained. And you're right, from the very beginning of the front desk, potential clients that call in, come in person, they all have to be greeted because they have to be treated as an individual worthy of coming for treatment. I've adopted the same philosophy here at the Essex County Jail, where I've delivered these services for about 19 years. And one of my basic curriculums is ACEs that we're currently going through. And I'm very, very, very pleased with your slide on social determinants. I will make copies of that and utilize that in the curriculum. So yes, as an organization, from the top down to the bottom, and myself, we've adopted this trauma-informed care.
Excellent, thank you. Thank you very much. Other folk? Anyone have any thoughts about their role in creating a safe environment for the clients you come in contact with?
Yes. Hi, can you hear me, Dr. Blackwell?
Absolutely can.
Okay.
Hi, Frederick. Why do I know you?
Uh,
I'm seeing people that I know from different spaces.
we've took trainings together, and we also trained together one time. So
Yes,
yeah. So how you doing?
I'm doing fine. How are you?
So my role in creating a safe environment for clients, I can control like when they're in my safe space, you know, and what helps me to do that is, first of all, being informed about what trauma-informed care is and how to implement it, and continue to get educated on it, but also, um, just make sure like the environment that I have with them is safe, and that I'm in a place that I need to be in when I'm providing care, to the people we serve. This trauma-informed care embraced by the spaces. I'm working on that, because I train, do trauma-informed care trainings, and I'm responsible for like training our staff and and everybody that works in the organization. A lot of folks don't embrace it, as they should, but I'm working on that, because so a lot of people get stuck in what used to be, and uh, so it's a process in changing mindsets, I just try to be an example, on how I do it, but all at the same time provide the information um, to the people in our organization. So
Thank you for that. And it is, you bring up a really important point. This is, and I think I said it a few times, this is not a one-time thing. This is something that you have to consistently lean into as an organization, as a provider, etc., where it is, okay, this is how I'm practicing today. How am I continuing to practice? Okay, providing the example, being the example, etc. Bringing it up in staff meetings. All of these different ways are things that you can lean into, really the embracing of trauma-informed care. The other thing you mentioned, and I wanted to just pull a little bit out of that and just add to that, is I need to be in a space. Okay. When we talk about trauma-informed care, it is very easy for us to lean into the participants, the clients, the consumers, whatever terminology that you're leaning into. But you also have to be in a safe space too. You have to be able to sit and bear witness potentially to someone's pain. And if you are not in a space to do that emotionally, how do you begin to address that? Okay. So trauma-informed care, the collaboration, the relationship is both folk, is all folk who are involved. It's the client, the participant feeling safe, feeling like this is a safe space, but also you feeling safe, that you can bear witness, do the work that is necessary. And if you feel activated, how do you process that? Okay. Do you feel safe processing it? And again, I could spend a few hours just leaning into that premise, because we're talking about supervision, we're talking about team meetings, we're talking about a variety of different places and spaces where if you are activated, how do you get the support that you need to continue to provide support to the clients? Okay, so that is definitely a part of this conversation. Grace?
So can you hear me?
Yes, I can hear you. We can
Okay,
all.
great. I have earbuds on, so because I'm outside walking. So one of the things that I like to share is I'm a little bit more multifaceted. I work with doctors in a monitoring program for doctors who have substance use disorder, mental health issues, but I'm also a licensed minister. And one of the things that I have been doing, and especially since the pandemic, is working with other pastors and ministers on what trauma informed really is and what it looks like and how it impacts ministry in our churches, because we have a lot of people who come to, I will say, Christ, since that's what we believe, come to Christ, but they also have issues and concerns that impact their ability or lack of ability to do ministry, to stay sober, and to be effective. And some of those include our pastors and ministers who also have history. And so it has been very rewarding, but also very, very tough in having ministers kind of do their own evaluation, their own introspection, and looking at how even some of the things that they say can also impact in their ministry with the persons that they serve in the church.
And thank you for bringing that up, because that speaks to culture, and it speaks to who and where our entryways can potentially be. Because for some folk, coming into a treatment program is not an option. Okay, but folks may feel more comfortable accessing faith-based organizations or churches or synagogues, etc. And so everyone needs to really kind of get a sense and be aware of the impact of trauma, and being thoughtful around what they are saying and the interactions and the environment that they're creating to decrease potential reactivation. Okay.
Michael, I want to share a comment from somebody
Sure.
else. Mic isn't working, but I think it really resonates probably with a lot of folks on here. So this is from Tom Shoemaker, and he said that he feels pressure to get the intake completed in one session. And this has caused him to not ask important questions, such as why therapy hasn't worked in the past, and what therapy has worked, and what therapy has activated traumatic memories. The facility has doors that close very loudly, and that also creates a startle reaction, not only in his clients, but also in himself.
Thank you for sharing that information, because while we can talk about the amazing work that is happening with many organizations around trauma-informed care, we do have to acknowledge that there are some spaces that are continuing to have challenges around this. One of the ways that you can begin to, according to your level of comfort, according to your level of comfort, well, let me address two things. One, the more physical space of doors that slam, etc., potentially working with the organization, maintenance, etc., to put like door stoppers so that that can address that on a very practical level. Okay. But again, that has to be kind of the openness to the organization. The other piece in regards to the intake assessment. Yes, we are absolutely all under time constraints to get it done. Some get one appointment, some get 3, some get 2. And what does that look like? One, during those initial conversations, yes, there may be a time constraint that you may, you feel pressure to meet that commitment. But also remembering that trauma-informed care is something that happens over time. It's a process. So while that initial assessment may not meet all of the needs, you can continue your work with the client and reshape that. So for example, one of the things that I've done when I'm doing an intake assessment in the past is I've said, you know, this is something that I'm working on, and this, you know, I have a limited amount of time to work on this. And I was wondering if we can kind of come together and focus on this and get through this process, but with the recognition that I'm definitely going to lean into other information as it comes up. So while we may not be able to do it this session, can or do you feel comfortable with us revisiting it in our next session or the next time that we meet? That's one. Two, I also lay the foundation around assessments, and any assessment, whether it's at the beginning, middle, because we do assessments in a variety of different spaces and ways. There may be questions, there may be things that I ask on this assessment that may create some feelings for you. You may have some strong feelings about. Please feel comfortable in letting me know that I don't want to answer that. Or can I answer that at a later time? And that's okay too. Okay. And you can put on your documentation, client did not feel comfortable answering this question at this time, versus client refused to answer the question. Okay, because when we put client refused to answer the question, that lends itself to a whole lot of other interpretations. But a client does not feel comfortable in answering the question at this time, with the recognition that you will at some point have to come back to that question. And again, how people feel comfortable. I start every assessment with that, because I don't know in that assessment what question could potentially reactivate someone or activate someone. So I say it from the very beginning, any question you don't feel comfortable in answering, just let me know, boom, we go right past it. Okay. I hope that was helpful.
Dominique was able to type in what she was trying to get across before when her mic wasn't working. And she's sharing that she's new to the field. So she's learning how to share her lived experience, but also, you know, herself a survivor of traumas and addiction, etc. And so that she's new in the job and it's a new process for her. So what might be some first steps or some thoughts on supporting somebody and how they can support someone sharing their experience without re-triggering themselves?
So, I love that question, and I could spend like a couple of hours on that question. The first thing that kind of pops in my mind in regards to that, Dominique, is I would need to talk with you further about that, because everyone has their individual experience. And, you know, part of what would be interesting to kind of lean into are what are some of the potential activation events or some of the activation opportunities that may come up for you. But the immediate kind of response is I would definitely seek out some supervision around that, right? Utilize your supervisor if you feel comfortable with that. A potential peer who is engaging in some of the same experiences of, because that's a big one, lived experience, and how much do you share? And if I share this, does it become, you know, something else? And if I share this, how do I feel at the end of this? And figuring out how to navigate that. I think leaning into the premise of supervision, leaning into peer supervision, talking with folks who have been in a similar, space or had a similar experience, how they've navigated it, and figuring out when you have that information, how that can look comfortable for you. Okay, so there is no one way to say this is exactly how you do this, because everyone has a different experience. Everyone is activated by different things or potentially activated by different things, and we want to be respectful of that. So I would suggest talking with your supervisor around it And if you don't, you know, because we want to also say that if you don't feel comfortable talking with your supervisor around it, leaning into a support that you can work this through. Okay, because you don't have to do it on your own. Okay. I hope that was helpful.
Does it work? Do you hear me?
Yes, now we can hear you. We
Oh,
can hear you.
yay. Yeah, I switched to the computer. Yeah, so no, one particular one is that my facility doesn't have the trauma yet. We're just getting into this because where I work at, we just work with addictions, mental health, halfway houses, the men and women, and people that are incarcerated, drug court, or reconciliation, stuff like that, if they get offense for drinking or drugging.
Mhm.
And now they're putting the trauma and mental health because we're seeing a lot of people coming in with mental health like never before. They're like coming out of the the woodworks with mental health, and now with trauma. Now I'm a particular one. I think the reason why they hire me is because I have lived all the lived experience you could possibly have, but survived. You know, I've been through sex traffic, drug traffic, child of a lot of traumas, gangs in and out, prisons in and out, jails in and out, addictions, you know, mental health. So like I have all of this stuff. So they give me those clients, but we're not in a space or facility to do that. We're not licensed counselors. We're just certified peer recovery coaches doing this, but we're not really allowed to open that trauma because we don't know how to get them out of it. And that's what I told my boss. And this guy came in and he opened up to me about him being sexually molested by by his mom, and his mom sold him off for drugs. And I was like, wow. I had the same thing happen, but it was my mom's boyfriend, so, but he didn't want to talk with me. And I was like, okay, uh, but there's nothing for men with that, so I was trying to look for something like that. I don't know, it was a special case. And it's still a special case, but I don't know how to do that and how to do this whole trauma thing without having a licensed therapist here, and how do we get them out? Because in my experience, uh, um, the psychiatrist, and I went to many of them, they kept opening up trauma, but they didn't know how to close it. And that led me back to my addictions. That led me back to self-harm, suicide attempts, over 15 of them, because the licensed counselors that had book knowledge and stuff couldn't help me close, or they brought something up that they should not had. So I don't know, it's a touchy subject. But just learning. So I don't know how to do any of this, but I like to learn hands-on experience. But I like this class. So keep going, give me more info. But I
Okay.
don't like this book by Oprah. Oh my God. I do not agree with it. Oh, I hate reading it because I do not agree what she says. But I don't know. But we have to do it because the work is having us do it. But I wish, and I told them, I was like, we should read this book instead. And they said no, they wanted to do it. And I'm just like, oh, it just rubs me the wrong way. I told them it rubs me the wrong way. Like she doesn't know what she's talking about. And I don't know. So it's bringing up stuff for me, but unfortunately, I have to read it, even though it's bringing up stuff for me.
So
So that's
one of
it.
the things I wanted to do, Dominique, is thank you so very much for sharing a part of who you are in this space and allowing us to hear that and see you. Okay. The other thing I wanted to, you know, and again, it goes back to literally when we're talking about this work, the impact that this work can have on us and the reactivation it can have on us is powerful. And so what I am going to suggest you do is that you continue to seek out knowledge. You continue to gather information. Think about your self-care plan. How do you take care of yourself? Because you are the most important part of the work. What you bring to the table is incredibly important. So how do you care for yourself? And also, as your organization moves towards expanding this, which is great that they're recognizing. Well, one quick second. Trauma, substance use, and mental health have always been interconnected. This is not a brand new thing. However, the understanding of that has become more intense, particularly with the pandemic, right? That we recognize that there's always been a high incident rate of trauma with substance use, particularly for women. Okay, so there's a lot of evidence out there. It's great that your organization is trying to do this work. It sounds as if there are some additional supports that need to be in place, and that's the transformative process. But also, if you feel comfortable being a part of those conversations around what this is going to look like because of not only your lived experience, but who you are. Because a part of this transformation process is the care, but also caring for the folks providing the care. Okay. So I hope that that was helpful on some level. Okay. I just wanted to get to Katrina before I move forward.
Hi, Dolores. Thank you so much. I just kind of wanted to piggyback a little bit off of what you were saying, just to kind of offer some feedback and suggestion really quick. I don't want to take up any of the training. What you have and what you're presenting is so beautiful. So thank you, thank you, thank you. But just to Dominic, and as a certified recovery peer advocate, and as well being in the field for over 7 years and a trainer of the Recovery Coach Academy, training people to become peers. That brought up a lot of stuff for me as I'm like listening to her and just thinking about suggestions and offering a bit of advice. So I guess my first suggestion would be is to remember that as peers, we have to manage our own stuff constantly on a regular basis. And what does that look like? And along with sharing our experience, we want to share the pieces of like sharing with empathy, right? So we don't have to really divulge a ton of our experience that will trigger in trauma, but enough to say, I have walked through some of those situations and I understand, and this is what I did to kind of navigate that and get out of those situations. As well as staying in my lane. And so, what that means for me is when people are bringing these traumas to the surface, I allow them to share to an extent. And then I say to them things such as, I think it was so special and important that you feel that you have a safe place here to share that. Is there anybody else you have shared that with? And if not, can we look into some referrals? Because I would love to see you get to the other side of this trauma. So referral is really big in like the peer world, because again, we want to stay in our lane. We want to offer that experience, strength, and hope, but we don't want to, start taking on things that are way outside of our lane. But again, I just wanted to offer that little bit of advice. And Dolores, thank you so much.
You're welcome. You're welcome. So is it okay if I move us forward? Because we have a total of like 32 minutes, maybe 30 minutes. Okay. Carrie's like, go. Okay. Okay. And remember, I said at the beginning, this is something that we can talk hours about. Okay. So let's talk about recovery planning. Okay. And again, we're going to lean into this just a bit, but this is kind of integrating that trauma-informed lens that we have, leaned into. So we know that in the process of working with folks around their assessments and working with clients around their assessments to get a sense of where they are in their recovery, and where they want to be in their recovery. Okay, that's one of the key goals of recovery planning, right? And this sets the stage for the relationship, asking those questions, leaning into the assessment, setting the stage of where they are and where they want to be. And if we're talking about the integration of harm reduction, where they are along that spectrum. Are they looking towards abstinence? Are they looking towards reduced abuse? Are they looking for safer use, etc.? When we integrate that into the recovery planning, it's a great way to set the stage for the relationship, but also get a sense of where people are in regards to their recovery. Also, we're gradually working with the client around their awareness of their feelings of the process recovery and the challenges to their recovery. This is where you begin to lean into things such as the social determinants of health, trauma, etc. What can impact their recovery is a key component, and really kind of allowing folks to work through this process with you, right? This is not a one-time thing. And the recovery plan is not a one-time plan that's it. That's where it stays for the entire time that you're working with them. It's an ongoing kind of dynamic process that can change, okay? You're looking at the whole person, the internal and external factors which can impact the client's recovery. And again, that leans into the social determinants of health and other factors such as trauma, mental health, etc. Okay. We are also working collaboratively. Sorry about that. There we go. It's back. Okay. So working collaboratively with the client to identify possible reactivations to their trauma. This is a big one. Okay, when we talk about recovery planning and we're talking about trauma-informed care, folks may begin to disclose trauma, right? Different events that are happening for them that they have experienced or are currently experiencing, etc., in regards to social determinants of health. And really, we need to lean into the connective tissue between the two. If we're talking with a client around recovery, and let's say they are moving towards an abstinence-based space, what can get in the way of that? So let's take, for example, a client who is dealing with PTSD, and they're dealing with flashbacks, nightmares, etc. And the only way that they can stop this from what they're disclosing to you is I need to use. I just need a break from this. Whether it's an hour, half an hour, whatever it is, I just need a break. Okay, that can be embedded into that cycle. I'm hurt, I'm in pain, I need this to stop, I'm going to use. But if you tell me, or if we talk about me stopping use or even decreasing my use, depending upon what I'm using, that then can put me back into that space where I'm feeling pain, right? And so if we don't have that conversation, we're missing a key component of recovery planning. There are folk who are using substances to deal with life. Period. Okay? Who are using substances, alcohol to deal with life. To deal with, to manage, to get a break from. Okay, so we want to include all of that within the recovery planning process. Okay, so we want to empower the client to begin to lean into the supports that they have, that they may have, and healthy coping strategies that they can rely on when they're in face of a potential return to use. And that goes back to that infamous words, the triggers to substance use, okay? What activates or reactivates potentially using. Okay, we want to lean into that. And we definitely want to develop a recovery crisis plan, which supports the choices around to whom and what supports they will engage in when they feel as if they're going to potentially going to return to use. So when we talk about someone who is dealing with active symptoms of trauma at that particular time, rather than me using, can I go and can I call a sponsor? Can I call a family member to help me work through this versus me using? Okay, that's the full comprehensive component of the recovery planning process and integrating the trauma component. We also know that we're empowering folk around their recovery plan, that they have a choice in maintaining, changing, or ending the plan, but that you will support them along the process, regardless as to how or when, whether they choose to end it. I want to change it. That's no longer working for me. I don't want to call that person because when I called that person, they weren't available, they weren't supportive, and I had to kind of figure out how to get through this and fight that urge to use. Okay? Or when I attempted to use less, it wasn't enough to stop. Okay? These are all a part of that conversation. Okay? So, we have some time for food for thought exercise. And so let's pull some of this together and let's lean into this a bit. Okay? And so this is our case study. And so just give you a moment, I'll read through it pretty quickly. Client A has recently begun treatment in your program, and during the assessment, Client A discloses that he was recently released from a 20-year incarceration a year ago and is currently on parole. His parole officer is requiring him to attend treatment, and he indicates that he struggles with anxiety when he leaves his place of residence and when he must deal with new people. He reports that he's returned to use since release to deal with his anxiety and his life circumstances, and he is currently unemployed and living in a residence. He's looking for work. He wants to reconnect with his family, and he reports that he feels his choices are limited due to his justice involvement and being a Black man in America with a record. He reports that using substances help to take the edge off. And he indicates that he knows he needs to address his substance use before he is violated and sent back to prison, but needs help. Now, this is a real case. When I use cases and stuff, I use real cases. This is a real person, okay? And so when we lean into the trauma-informed recovery planning, right? We're going to help put together a recovery plan. But I'd like for you to think about the core principles of TIC and think about the key items that you would consider working with around developing his plan. So we know we need to lean into awareness, safety, trustworthiness, choice, collaboration, and empowerment. And I've given you some interesting information about of some things we need to consider. Okay? So would anyone like to take a shot at this? I'm using a fairly interesting word, but would anyone like to take an opportunity to share?
My name is Eric Wright. Can I be heard?
You absolutely can be heard. Would you like for me to go back to the case study?
Yes, please.
Okay, there you go. And you're on.
So my background is in law. So working in housing, being a housing case manager is kind of new for me. And I'm so happy we have this question here because I think this question gets to where the rubber kind of meets the road or the pink elephant in a room type situation. So the people that we deal with are very, very smart. They're smart because they know that there's nowhere to go. Where can I seek help? Or if I seek help, will I get the right kind of help? So they recognize that there's no place to go. And that's when the that's where the where your heart starts to kind of turn black, or that's where you start to lose hope. And that's a very dangerous place. So first and foremost, the system needs to be changed a bit. And then after that occurs, then you deal with the reality of explaining to the person, okay, listen, all right, this isn't all your fault. Okay. There were some things that probably happened before you were born that you may still be dealing with. And I understand that. And we've all been there, and you kind of relate to them on that level. And then once you can get them to see the big picture of how, maybe this isn't all our fault. There's some things structurally with our society that needs to change. Then we can kind of start giving them hope again, start relieving some of that pressure off of them, and putting the pressure where in most instances it rightfully belongs, on the situations that cause them to be there. And I think if you ever dealing with somebody that's been in a criminal justice system or in a legal system, or just dealing with a situation that they're unfamiliar with in general, and they don't have the family support, that alone would cause trauma for any one of us. But then you add the elements of drugs or alcohol or abuse onto it, and it just intensifies it more for those individuals. So, and I think all of us, and if we have an understanding of that, and we all work to make the system more just, correct historical wrongs, and do things like that, where if we all do that, then eventually we're getting to a place where there's no one in our society that'll be left behind, the because we have the resources, we have the people who are smart enough to get things done, but there are a lot of things in the way of having that done. And that's where we have to be a little bit better at understanding the problem and explaining the problem and fixing the problem, and passing the message on. And that's where we get to where we can really impact people, going through what this man is going through in this case study. Thank you guys for listening, and that's what I want to say.
Thank you. Thank you so very much. So from your perspective, if it's okay if I provide some comment, is from a larger system approach. Like, we need to address the challenges from a systemic approach.
100%.
Okay, gotcha. And that's something to consider. It absolutely is something to consider. Other folk? Do folks need me to go back to the second slide with the awareness? Oh, Dennis, there you go.
I think the first thing that we have to look into is some of the intangibles here. If a person is being released from 20 years in incarceration, I'm thinking that is probably murder. Two, I think we have to look at a safety plan, first of all. One is a safety for himself and safety to the community. So first of all, we got to find out a little bit more about the information regarding his incarceration. Anxiety that he reports could be a number of different reasons. Is it safety for himself? Is it safety for others? So some of those objectives that we have to look at, first of all, is that going into treatment for his substance abuse, coping with his past and present situation by using substances. Again, it might suggest past trauma, and that's got to be investigated, explored, and discussed. All the other things as far as treatment plan, looking for work, these are basic things that parole is looking for an individual being released from prison. But I think the key component would be safety for self and others.
Okay. There were some other folks who had their hand raised. I see Dominique, you have your hand raised.
Yes, thank you. I like the situation, but it all depends on where you work and sorry, what county or what state you're in. So depending on what that is, I know for Indiana, Porter County, coming out of that, I know there's only so much that I could do limited here where I work, but I do a lot of street outreach and with the homeless and just I just got stopped. I just got told not to go in the crack houses and the trap houses and stuff because I'm that kind of person. I go, you know, like Jesus did and go get that one. But so I would run into this on the street. But I mean, if this was brought to my clients, yeah, we have to really look into this and ask him, what does he really want? Does he want to stop? Is he willing to stop? From 20 years of incarceration, yeah, it might be for murder, but it might be wrongfully, maybe it's in and out. I mean, there's so much to ask for this, but to get him to the right place. As an African American person, does he really want to not really be in Porter County? What county does he wants to be? Where's his residence? Is he willing to go? Because there's a really kick butt program in South Bend. It's called the DMAS House, DIMAS House in South Bend, and they deal with people like this. But I don't want to say people, um, but just with people from incarceration and help them, and they reside with them. They help them with all of this information. So having us resources for this and reaching out to them, but also having that relationship with them. Our first relationship, the intake might be too much for him, but having him come back and having that bond and my place, I can't meet him for coffee or nothing, but try to get him to come here. But I would like to be in this man's place. I mean, if he's drunk or high and I call him, like, that's fine. You know, I'll meet you where you're at. You know, it doesn't matter. You know, let's just get this and what's going on and get the resources and help him call. Does he want the case manager? And if he wants to go to treatment because he just got locked up for 20 years. So if he goes into a treatment center, does that, going to frighten him more from being incarcerated by not doing MAT, stuff like that. So we have to like really dig, I don't say dig deep, but use each other. So I could call my sister, Dolores Blackwell, like, hey girl, like I have a client, blah, blah, blah. Do you know anything? Here's a situation. Like we could use each other, or I could call and get that information instead of say, oh yeah, you're going to have to go to Ms. Blackwell's office. No, no, no. We're going to call Ms. Blackwell and see if she has an available appointment and she can meet this person and be like, okay, I have a connection for you. Call Ms. Blackwell. Here's the number. She's only available Monday and Wednesday from 8 to 12. Get them the right direction and hook them up with other people that experience this similar atmosphere and get him into the recovery community and let him get back and let him make the choices on what he wants to do and stuff. But I think it's all into one that we could help this person. But I like this.
Excellent. And so far, it seems like we've talked about awareness of the different challenges he may be having. We've talked about collaboration. We've talked about safety, okay, empowering. So we're covering it in a very thoughtful way, which is great because we also are aware of the system, right? The different systems. We also, I think someone mentioned the impact of trauma of incarceration, right? The anxiety of leaving his home and leaving, dealing with new people, and the potential that the substance use is the way I contend with this, the way I take a break from it, okay, from all this stuff that's going on. We also do need to acknowledge that looking for work, so that's one of the social determinants of health. It could be a real challenge depending on where he is, connecting with what Dominique mentioned, depending on where he is, finding work can be incredibly difficult. Also wanting to reconnect with his family, so there may not be supports, we don't know. So we have a lot of information here, but there's a lot more that we can ask based upon thinking about this from a trauma-informed lens, okay? Carrie?
Absolutely. I was just going to echo a lot of those sentiments in terms of there's a lot of validation and acknowledgement that needs to take place in talking with this client. in terms of his anxiety, around people, new environment, 20 years incarceration, the amount of trauma that experience alone has had on him. And I think also exploring his ambiguity, because he shares that he wants to avoid prison and he wants help, but he's not sure how to go about that. So exploring that some more, and what would it take, and working with the parole as well, because he shared that parolers set him up to mandating treatment, and then he shared, well, he's really anxious meeting new people and new groups. So what does this treatment plan look like, and how does that work with what he shared in terms of his anxiety and experience? But thank you.
So this is a recovery plan. When you think about all of this, this is a recovery plan that has so many different aspects that we need to take into consideration. In our work with the client, we're taking all of this into consideration. And kind of the finer point is, what does the client see are the priorities to help him in his recovery, right? Because we can have all of this information, but what do you think you'd like to work on first? What do you think would be helpful to support you in your recovery? That's the full circle of the empowerment. That's the full circle of giving agency. Okay, what would you like to work on? He might say, I want to reconnect with my family, because I feel like if I can reconnect with my family, I can get some support. I just need somebody to talk to. I need somebody to be in my corner. Okay, and the reason why I'm saying that is because that's very much what the conversation looked like. I need support. I need someone to just be there for me as I figure this out. Okay, I saw Dennis, and I think someone else raised their hand. Dennis?
Yes, I want to continue on this safety thing because he's been there for 20 years. He's been conditioned in a different environment. And a lot of it is self-preservation that he's been conditioned to. He may or may not be institutionalized, whatever that definition might be. Here's an example. A person, there's unwritten rules that are in prison. In a real life situation is a person that was incarcerated for 15 years for a murder charge. And he talked about the difficulty of acclimating back to the community. He spoke about an example of being in Walmart in line, just being another patron there. Someone cut in line in front of him. What would the reaction be in prison? Violence. How does a person restrain himself from being and reacting to his previous conditioning? So those are some of the intangibles that need to be understood besides going through the normal route of developing a treatment plan.
Absolutely, and we're going to be talking about that in our next opportunity around folks with past and present justice involvement. We're going to be leaning into some of that, because the coping strategies that helped someone to survive incarceration, right, may not be user-friendly in the community. But that doesn't mean that we also want to work, we don't necessarily say to the client, hey, this is how you should adjust that, okay? Hypervigilance, which is something that helps folks survive incarceration, can be muted. But we also may need to work with folks on how to mute it. Okay, so these are all things we want to consider. All things that we want to consider.
Yeah, I just want to say a lot of people said a lot of the things that I was going to say, but first you just acknowledge, that a lot of his feelings are valid. You know what I mean? What he's talking about, and what he's going through. And and focus on the last part where he indicates he knows that he needs to address his substance use, regardless of what the reason is. It may not be he may not have a substance use disorder, but if you're in the criminal justice system and they say you can't use, you know what I mean, or you can't drink, then that makes it a problem.
Mhm.
You know what I'm saying? So we address, we meet him where he at, and ask him, what do you think would work for you? And as he beginning open up, then that's when you have the opportunity to present to him the resources, that can help him in different areas. Up here we have like reentry programs where, people can help you adjust to getting back to society. 20 years is a long time, especially if we're talking about from 2000, into 2024, a lot of things have changed dramatically, and so, sometimes you don't even have to be incarcerated to have anxiety behind all the changes that took place, in the last 20 years, you know what I mean? So you validate all that and just try to meet him where he's at. And like you said, ask him, what do you think you need? What you think might work for you? So.
And that's one of the key concepts, and thank you for that, Frederick. That's one of the key concepts of trauma-informed care, the awareness that all of this has a role to play. And the client will let us know what that role is. Okay? When we talk about trauma-informed care, it's not that we kind of leave it there. We read it on a paper or we read it in a screening form. We respond to it. Okay, we create a space where the person feels like they can talk about it. They can expose vulnerability and not be hurt, because that in itself is that's what's the experience? It is a corrective experience where folks can be vulnerable and not be hurt. Okay. So thank you for all of that. I want to definitely be mindful of the time that we are in. This was an amazing, amazing conversation. I so appreciated it. And so we are actually moving towards our time ending together. And so I wanted to leave a few moments to see if there was any questions, feedback, or final thoughts that folks would like to share. And
I just want to say that the chat is filled with accolades of people thanking for this incredible training, awesome training. Thank you for your time. People asking when the next one is. I put up that information there, but I'll free them back up for, I think someone had their hand up, but just wanted to share that with you, Dr. Blackwell. Thank you so much.
Thank you. I definitely was going to say, please check the chat because there's probably a whole lot, because I see a bunch of stuff happening in the chat. And, and I just wanted to apologize that I'm not ignoring the chat. It's just that in the process of doing the presentation and being present, I missed something in the chat. So that's why it's always great to have a team of folks who can say, hey, this came up in the chat. Okay, so thank you for all of your information sharing, comments, everything in the chat. It is so very much appreciated. I saw someone whose hand popped up.
I don't know how to raise my hand in this thing. So
okay, that's fine.
So I just wanted to say to everyone, again, my background is in law. I did finish law school in 2004, so I've been doing this for a very long time. And in the 20 years that I have been doing this, I too, the reason why I'm in case management now is because I kept hitting the glass ceiling in the justice system. I saw, things, police, judges, prosecutors do things that they didn't teach you would occur in school, and that kind of darkened my heart a little bit, or woke me up from the reality that I can do this on my own. So it does take a team, and whatever your team is, it does start at the top, and the focus, in my opinion, overall has to be to influence. And once we get into that influence mode, then our policies that we are doing at our offices will get into the hands of our state and local representatives, and then maybe it gets into government or how we vote. um, and and of course we have to do what we need to do, what we are hired to do, whatever our jobs are. But definitely, as we're doing our jobs, a part of informed care is understanding the bigger picture. Because if you don't understand the bigger picture, how can you really do the informed care? Especially when you're dealing with people whose primary issue is the justice system.
Mhm.
And so that starts with understanding the limitations of the justice system, and you can kind of um, help people fix their expectations, because a lot of times the expectations of what the justice system can do is here when it really should be, maybe at the ground, So that's all.
Thank you. Thank you so very much. There was someone who had their hand raised, and I was going through the participants to see if I could see who that person was. It started with a C. So if you would like to, if you'd like to unmute yourself to comment, please feel free to do so.
You're gonna send us the slides and the CEUs and stuff, right, to our emails?
Yes, you're going to get all of that
Okay.
information.
And then any other worksheets or slides or worksheets, or maybe something that we could do examples, or any other info or resources would be good to learn more. And any other books other than the one that I'm working with, What Happened to You? Like, I don't know, like any other resources that I could get into. But yeah, thank you.
Awesome. You're welcome. Jose, I see your hand raised.
Yeah, thank you so much for this class and for everyone that's shared. It's been an enlightening experience. I always have trouble sharing opinions or even my experience, just because I'm still relatively young in the field, working in social work for roughly 10 years, but only just recently achieving my MSW last year. So it's like, um, I'm in Rochester, New York, and we are considered the murder capital of New York State, even though we're a tiny little dot, even though we have the most resources readily available in the entire country in terms of social welfare, in terms of social economic infrastructure support. And we still have number 2 poverty in the country and number 1 child poverty in the country. So there's a lot of things that we have to know as social workers in law regarding policies, regarding social economic infrastructure, where it's broken. And part of the upheaval is working one clan at a time without the pressure of being able to change the world as I see it now, but working with the client that I'm working with in front of me as they are. And like you mentioned before, the sense of awareness has to definitely stem from knowing the compound disparities of the demographics we're working with. I currently work with the chronically unhoused. And so the demographic I work with are people with substance abuse disorder, people with egregious law um, um, backgrounds, where they've been in prison 10, 15, 20 years, whatever it may be. But if there's anything that I can bring to the table from my humble little experience, but with many mentors who are masters in their craft, is that truly coming objectively to the table to meet each client where they're at is the best way to build rapport with the client, for them to feel safe enough to come forward. And when they start speaking, looking for all the strengths, because we have a strength-based perspective up in Rochester, New York, and evidence-based practices. Even with that client that you mentioned before, whether or not he was forced to go into treatment, he went to treatment. Whether or not he was in prison for 20 years, he didn't commit suicide, despite the statistics of people committing suicide in prisons the longer that they're in there. There are a lot of facets in there that are not meant, that were not mentioned, that I see, I'm like, okay, this is where I can show him you're actually taking steps forward, or my clients in general, and just being objective to the fact that every choice is subjective. And the moment I take away my idea of what's right, wrong, safe, happy, you know, and looking to the client as the expert of what that means for them, is the moment they see that I'm actually someone standing in their corner and not someone trying to colonize them with the idea of what it looks like to be a quote unquote outstanding citizen in their own society. And so and that's, I think, when we step, and it's very easy to do that with a clinical mindset of just being solution focused. And when we step outside of that clinician's mindset, which is useful when it needs to be useful, and step more so in the person-centered quality of life, what's the term? Just the validity of the person, being a person and having the ability to choose and free will, is the moment they were like, wow, this person's actually standing in my corner and not trying to make a corner for me to stand in.
Mm,
So you know what I'm saying? So like,
it's powerful.
right now, so many of the people I deal with, even myself being a Latino social worker in my field dominated by middle-aged white women, and being a gay man in America, and even my spiritual background, I face my own compound disparities that I can easily allow to be triggered when I'm working with the community I'm working with. But once I stand outside of myself and realize that the moment I start using my own opinions is the moment I've lost my client, whether they see it or not, because it's going to project into the way I practice, into the way I'm internalizing the situation of each of my clients, and the judgments, which shouldn't be there in the first place, towards my clients, which will navigate where I guide them or how I listen to them.
Mhm.
It's so multifaceted and it doesn't have to be. When you just say, hey, this is a person, this is a human, client first, that whole background that you gave us with that vignette is so simple to respond to without looking at all the details, with just, okay, here's a person, they've suffered, my background information knows about the policies within the state, and now it's my job as a care manager to help them go through the hoops and loop things together and work the system the way I know it can be navigated for people who already abuse it, but for good. And show them like, hey, when you go through here and you say this is a household, you can get, DHS, or if you want, food, there's plenty of cupboards. And hey, you don't think you can get a job because you went to prison, but let me tell you about the programs that are kind of being gate kept, but I know about them, that will help you get a job. That's our job as detectives in the social structure that we're working with. Because just like complaining, man, our system is broken and it's failed us again, is kind of like complaining that a two-leg chair won't keep me up. You know
Mm,
what I mean? Do you know what I'm saying? It's like, it's not going to do you any good at all to stress about that, but it's also the focus of how to keep my self-care in place and keep my mental stability sound, by just knowing that there's things out of my control, and that's okay. And there are choices that my client's going to make that, to me, if I internalize them, is going to be like, this is crazy. And that's got, and I've got to be okay with that, being
yes.
responsible to my client and not for my client.
Yes. So thank you for that amazing, amazing feedback. It is so very much appreciated.
Yeah, that was
Um,
powerful. Thank you.
Thank you. It was super powerful. And so there is no better ending than for us to end on that powerful note. I've put up the feedback survey that is there. We ask that if you can take an opportunity to fill that out. That has also probably been dropped in the chat. Also, the information for the next training, I think it's February 12th, has potentially been, yes, I'm getting the nod that it has been dropped in the chat, where we will be leaning more into folks who have justice involvement. As Carrie mentioned, there are a number, I think there's about 4 in this particular series that we're going to be working with. So please be on the lookout for additional professional development opportunities. And again, I'd like to thank everyone who participated in this amazing, amazing collaborative learning experience. And I wish you all a great rest of the day.